It is my pleasure to introduce Dr. Lianne Urada today. Her research focuses on developing interventions with policy and practice implications to address homelessness, human trafficking, and HIV/AIDS. She's principal investigator of a National Institute of Drug Abuse R21 grant that developed and tested a tele-buprenorphine pilot intervention for unstably housed individuals using opioids at public libraries, in partnership with Father Joe's Village Health Center, and the San Diego Public Libraries. Her works was covered by KPBS and NBC7. And I'll let you take it away, Lianne. Very excited to hear about this project, and so I won't hold it any further.
Good morning, everyone. Thank you for joining so early in the morning. I see some of my co-investigators here on this project, such as Dr. Richard Garfin and Jordan Jump, and any others who may be joining. I'll be sharing my screen now and starting with actually that KPBS video that was done on the study at the very beginning, and now we're at the end. Here it is.
There's a new partnership aimed at helping opioid addicts in San.
Sorry, let me do the video.
The 9th floor of San Diego's Central Library has a view of downtown and the streets below. It's where I met David Houle, who is currently homeless. A native of Phoenix, he says he's battled with addiction for more than 20 years.
I've had my dry spells, I've had my good spells. And coming here, it just went really bad.
Then he saw a flyer at the Central Library telling him about a program aimed at helping people addicted to opioids with a drug called Suboxone. Its primary ingredient is buprenorphine. Houle says he responded and signed up for Suboxone treatment at Father Joe's Villages.
After, talking with the doctors at Father Joe's and taking it every day, getting to that right dose, it had really helped me a whole lot. And I have had slip-ups. I have talked to, Dr. Urada, and we both know that that's normal, but it's never gone out of control. I take my strips every morning like I would drink a cup of coffee.
He says it's as if the drug has mentally blocked the cravings he used to feel. He gets the medication on a small strip that he places under his tongue. Buprenorphine itself is actually an opioid that binds to a person's opiate receptor and can knock more dangerous and potent drugs off of it. Dr. Daniel Lassoff is an emergency physician and toxicologist with UC San Diego Health, who has prescribed buprenorphine many times.
So it's great. We can see things like pain relief, treatment of withdrawal, treatment of cravings, but we don't see so much of that euphoria that we would see that drives people to start abusing these drugs.
Megan Parch is the chief health officer at Father Joe's Villages, which is just 2 blocks away from the downtown library. She also prescribes buprenorphine in the form of Suboxone.
We've seen people stabilize. We've seen people reconnect with family. We've seen them obtain income, housing. We've seen people find and maintain jobs that were unable to prior.
Suboxone contains both buprenorphine and naloxone, better known as Narcan. Parch says she has seen the problems of drug use and overdoses grow exponentially in the homeless community, due largely to the widespread use of fentanyl. San Diego State social work professor Lianne Urada says she has spoken to librarians who talked about frequent drug overdoses in the bathrooms and outside their libraries. Urada got a 2-year grant from the National Institute on Drug Abuse to see if intervening with buprenorphine could make a difference. 2 months ago, they began reaching out to people with drug addiction who use the Central Library.
So many people do want to get help, and sometimes just a little bit of help, like just us finding them the next day, it makes a world of difference to them. And they tell us that, just knowing somebody cares.
The old library mission of public service by promoting literacy and providing information has evolved. The library has also become a place where homeless people go to use the bathrooms, charge their phones, be dry and safe. San Diego Central librarian Jennifer Jenkins says libraries confront a changing urban environment and changing responsibilities.
Libraries have now become dynamic and reflexive and kind of respond to the needs of the community in real time, as opposed to holding those traditional values and missions and not expanding and growing with our communities.
The San Diego State Project seeks to recruit at least 40 addicted people to get Suboxone prescriptions and take it regularly. Urada says she hopes this will be a model for the rest of the library system and perhaps libraries in other states. But Lassoff says we need to remember that detoxification by using medicines like Suboxone is rarely enough to make the problem go away.
Substance use disorders are chronic diseases. It's the same way with asthma, diabetes, hypertension. These are health problems that wax and wane, and people have relapses.
He says long-term treatment needs to be part of the solution to turn people away from drug abuse. Thomas Fudge, KPBS News.
Oops. Wow. Okay. Making sure you're all still there and you were able to hear that, right? Okay.
Yeah, that was perfect.
Okay, great. So now I'll talk about the study. Okay, so the videos you saw, that was at the beginning of the study, and really about a year ago, about a year and a half ago. And now we've ended. I'm actually submitting an R1 this Wednesday, fingers crossed. And so I'm a professor both at San Diego State School of Social Work and also in Global Public Health at UC San Diego as adjunct in the Department of Medicine. And this was just a pilot study for 2 years with R21. It's called Bupe by the Book. And so we developed this and we tested the tele-buprenorphine intervention at the public libraries, at 2 public libraries. So this one is the San Diego Central Library and then also the Mission Valley Library. And this is the team of co-investigators and doctoral and public health students and social work as well. So the reason why we landed on this idea was because overdoses were happening, in the public libraries. So I had done an initial needs assessment there in partnership with the downtown library. They're happening around the libraries even twice in a day, according to a focus group, which was much greater problem than even the library thought, which was because they were having overdoses around monthly. But those who were unhoused immediately around the library said it was happening much more often. And as we know, it's still continuing to do so. So as you saw, we were covered quite early on by different news outlets as well as San Diego Tribune. And the idea was to have a place where those who were actively using opioids can go to the library and actually do telehealth from a private study room. There's study rooms on every floor that the public can reserve for a couple hours. So we had, in partnership with the library, we had a dedicated study room where they can go and do their telehealth with Father Joe's Villages on the other end. And we would meet with them weekly as a research team to see how things are going. We'd give them either a survey or qualitative interview. For 12 weeks, we followed up with them. And this is a randomized trial. So we randomized, our target was 40, but we ended up enrolling 60. And we randomized them either to do telehealth in the library or to keep going in person at Father Joe's villages. And we ended up enrolling 60 who actually went in person at the first visit to see to see a provider and get prescribed buprenorphine. So this is how we knew that they could be eligible for the study when they went all the way through. They did a baseline with us, but then they actually saw the doctor, and that's what qualified them to actually be enrolled. Because we actually screened 208 participants, but only 60 actually made it to see the doctor for that first visit. And then from there, we randomized them either to the telehealth group or to the control group. And so this was okay because this was a pilot, and it took us, really only about a year and a half to randomize them and to follow them for 12 weeks, the 60. And so now for the R1, we'll of course propose to scale it up to a larger number, such as actually enrolling 200, but over a longer period of time, such as 3 years. So you can see this is the consort diagram, which shows the details of, who ended up not being part of the trial, and how we had pretty much even numbers between the telehealth and control group, around 32 for telehealth, 28 for the control group, and then those who were lost to follow up for various reasons. This is I know the program officer, it's very appreciative of how, really difficult it is for participants to stay in a study like this when they're unstably housed, often losing their, phones, not having phones or email access. So for us to be able to, retain them was actually quite an achievement. So this is just the easier way to see that diagram. We do have 180 that we did baseline surveys for, and then we followed up the 60. So we have follow-up data for up to 12 weeks. And so we included everyone who was enrolled, even though there was attrition, approximately around 20, making it really around 40. But of the 60, this is the demographics. So in the end, we had, over half were non-Hispanic white. We did have about 23% Latino, Latinx. Black African American was actually small here, 8%, but there were more who were baselined and screened. So unfortunately, there were many who didn't, end up enrolling and seeing the doctor and taking the buprenorphine. So that's why some of these numbers are a little bit lower. Plus the multiracial also includes some Black African American, but I think that it does speak to having maybe a more targeted strategy to reach that population, because downtown you have many who were unhoused, who are Black African American. So we had about 45 men, 15 women, and you see the breakdowns in gender, telehealth group, and the control group. For the gender, we did have some who were transgender, a few. And then also for the age, the average was 42 years for telehealth, 49 for control. But the range was quite large. So we had 25-year-olds all the way to 69-year-olds in the study. And so the criteria was that they had to be unhoused, unstably housed, so they could be in shelters, but a majority were on the street. And secondly, they had to be using opioids. the majority were using methamphetamines at the same time, which I think characterizes this population in San Diego and in Southern California. But the wonderful thing is we did have success in that 88% of the telehealth group picked up a buprenorphine prescription at least once, and 63% for the control group. And then in terms of picking up prescriptions even more than once, so 2 to 10 times, 85% of the telehealth group did so, and 48% of the control. And then we're able to track on the Cures database and see that there were several that were still picking it up months later, because the study was 3 months long, but even seeing like 7 to 8 months later, there were some still picking it up. And so in general, the majority did retain in the study for at least 8 weeks, if not 12 weeks. But that was probably the biggest challenge is for some is staying for, a majority of the weeks. So over 50% of the weeks. However, there were some who really wished that we had extended the study for more than 12 weeks because they just got used to seeing us in the library every week for 12 weeks. And we did give them incentive like snacks and drinks. They loved Gatorade. And we gave them $20 for every visit. Because what we did was we did a urinary drug screening for all drugs, including a fentanyl strip. But we're really trying to also capture if buprenorphine was in their system, so to show that they were really taking it. And then we also did, spend time like an hour, half an hour doing follow-up survey or qualitative interview with them. So every week, so they really became kind of attached to our project or almost dependent on us. Giving them even resources and helping them along the way. So only approximately 5% in both groups knew where to get buprenorphine before coming to our study. So I think just having them know about it and uptake it was a big success. And then they also reduced and stopped their substance use many times more if they were in the telehealth versus the control group. And this shows some of the breakdown. So for example, 36 of the participants reported a decrease in their drug use. And then 24% reported a decrease specifically of using opioids, 60% of them being in the treatment group or the telehealth group, and then 29% reported a decrease in cravings. And so this was the self-report data, but 75% were in the telehealth group. And these are just some quotes. They said, the library is close to where I stay, so having access to places to charge your phone, laptop, and Wi-Fi. The atmosphere is more comfortable than going to Father Joe's villages. So this was one participant. And would rather do telehealth instead of walking all the way to Father Joe's villages. I'm frustrated with having to go back in person for an appointment today, and I'm tired of getting caught in the rain. Having telehealth in the library sounds great because there's a lot of hassle when it comes to in-person doctor's appointments when you have to check in early. Now, there were some who were quite happy to still go in person. They saw us in person at the library, and then they still went to Father Joe's villages in person because not everyone experienced barriers going to in person, and sometimes they preferred in person. Like being all on telehealth during the pandemic wasn't good for everyone, but it was good for others, right? So that's why we did an intent to treat analysis. So we're including everyone, even if they're in the telehealth group and didn't do telehealth, we still consider them in the telehealth group. So looking at this, 42% tested positive for buprenorphine of the 60. And if they're in the telehealth group, they're 2.5 times more likely to take buprenorphine versus the control group. And if they're in the telehealth group, they're 2 times more likely to see a medical provider more than once versus the control group. So the lessons learned here was really that it was challenging to make the telehealth run smoothly. So partly what we're looking at for this pilot study was the feasibility and acceptability of the telehealth. The participants, for the most part, if they were in the telehealth group, and even if they weren't, they all expressed, willingness, if not desire, to do the telehealth. But there were some challenges that we, tried to work out, and one was sometimes, just making it happen smoothly in the library. We really needed, it really seemed like the participants needed our help, either from a library, it could be a library staff, but we were there 2 or 3 days a week in the library, so we were the ones helping them facilitate that telehealth, and that seemed to help. So we did not quite test out if they can just do it completely on their own, only with the library's help, but it was set up to be that way. The other thing is that, so we did get a supplement, and we did try to take on more of a case management role in trying to get them to, go to their doctor's visits or do the telehealth in the library. So that seemed to help. So there's implications for that, because for this population, I think they did appreciate more of that direct help. And then also sometimes they didn't have a library card, they didn't have IDs, so it was hard for them to either pick up their medications at the pharmacy or to be able to check out things at the library. So having this iPad on a stick at the library in a room all ready for them, where they didn't have to check out a laptop at the library, that was supposed to help as well. Let's see, and we really tried to keep it sustainable, so that it could be scalable, so that there isn't really funding necessary to do telehealth in the library. So Father Joe's Villages, they did help us with medical record data and meetings and everything, but we tried to intentionally, they also tried to keep it where they didn't have to do anything extra for our study other than that. And then the library also, where it didn't have to impact their duties too much. As I mentioned, we did the intent to treat analysis. Polysubstance use was quite an issue because methamphetamines really seem to dominate, as well as fentanyl use. And so, buprenorphine is really meant for opioid use, but there were those who said they thought it was cutting their cravings for meth use and everything, as we had heard initially, in some of our focus groups in our first phase. All right, so we did establish the feasibility and acceptability, and now, as I said, we're turning in this R1 application to try to do an efficacy study for with about 160 to 200 participants. Here's some just additional quotes that they said: it helped me sleep, it cleared my head, I was able to think much better. The biggest change has been my lack of craving for using drugs. Another one said that Suboxone helps me to follow through with interviews. I left everything at the campsite, applied to a job, had a group interview. When you're on the street, then it's harder to follow through. And so I just want to acknowledge everyone who was involved, the UCSD and SDSU teams, also the doctoral students and masters in social work and public health students. There's quite a lot of teams, and we have some social work interns at the library, which is how I first established that connection, was helping to set that up. And then also, that's the public library staff, which really is, they're undergoing some, huge cuts in the city right now. And so, but they're still cooperating with this application going in. And then Father Joe's Villages, of course, Dr. Megan Parch and her team, and my program officer at NIDA. And again, here is us at the beginning, the Father Joe staff and some of the students. Okay, so I know that was a little bit quick, but I would love to hear questions and have any kind of discussion, especially around, follow-up is always a challenge, especially when people don't have phones and regular email access, the participants. So that's something we definitely, found if we followed up with them the next day, it would help, but we weren't at the library every single day. So, maybe that's what we need to do is to be there every day, because the participants really what happened with the follow-up was that they knew when we were there, that they knew we were there every week on what days of the week. And so they would just come on their own. They would just remember and make it part of their schedule. Because like I said, calling them and emailing, it only helped with some, not with everyone.
Thank you, Lianne. That was really interesting and nice to see the video and everything kind of happening in real life. I have several questions. I don't want to take over, so if anybody has any questions, please just interrupt I'm checking the chat and everything. The first question I had, and I think you went through it, is regarding the staff at the library. What was their training through the study? Did they learn about opioid use disorder, about buprenorphine, about how to connect them in telehealth? Was it a long training that they got?
No, but you know what? I'm going to write that into this grant because I think that would help, especially with the security staff. The funny thing is, at first, the library said, well, let's not advertise the study too much, even among the staff in the library. The primary thing was trying to keep it confidential for the participants because they don't want to be targeted, right, as someone who uses drugs and they're in the library. So that strategy kind of imploded on us because inevitably there's quite a lot of security in the downtown library as opposed to just one in the Mission Valley Library. But they kind of converged on us at the start when a participant was, they accused of being in the bathroom and using drugs and wanted to kick them out while they're in the middle of doing our study or the interview. So we quickly realized we needed them to be our allies, and that was one thing. But we didn't do. I mean, they're already trained on the security staff and some of the staff in the library, which is like 100 staff. They carry Narcan and they actually do revive people, using naloxone. So they have some training. They do get trainings, but we just had kind of meetings with them. We didn't do formal trainings. We were trying to have not burden them. And I feel feeling in this climate of budget cuts, they'll want that even more. But we are going to try to have a larger role for them and more train them as we move towards, implementation science kind of measures.
Yeah, I was thinking it'd be nice if they had like harm reduction training and learn more about the philosophy behind it and just kind of, because it's not necessarily linked, like naloxone training doesn't necessarily come with the harm reduction spirit. So I'm gonna let Shannon ask her question and then I'll go through the chat.
Yeah, thank you for the great talk. I was just curious if there was any, if you guys looked into or just anecdotally what your experience was with helping folks with keeping their med supply. Like, do they have any sort of lockers on site so people could, store their doses? Were doses getting stolen often? Just kind of curious about that aspect, that barrier for folks.
Yes, that was a problem, even with these locked medication pouches that they sometimes used. So actually, it's a huge thing because Suboxone, taking that daily, the strips, if they weren't reluctant to take it, they were also saying, yeah, it gets stolen sometimes. And now with Sublocade, the injectable medication, really being pushed even on the first day as, being okay. Now, I'm not sure if this would change the dynamics of the study because we are, doing the Sublocade, the injectable medication needs to be in person, obviously. So it would kind of take out that effect of the telehealth. So, but we'll see how it goes. I mean, I do think the injectable would be great for participants to not have to worry for 3 weeks to a month about taking the medication. It would just be in their system. So, especially for those who are unhoused. So maybe that's the way of the future, but we will see. Yeah, it'd be great to have lockers at the library, but I think that's been proposed, and it'd be great to even have places to sleep at the library, but that's I think not what they're trying to do.
Thank you.
Thank you, Lianne. There's a question from David Brelotti. Do you want to ask it, David, or should I go for it? Okay, I'll go for it. So David was asking if you collected any objective evidence of a change in methamphetamine use with buprenorphine treatment, and if you did any testing to accrue buprenorphine adherence.
Yeah, so we did the urine testing every week in the library for the buprenorphine, and as well as all the other drugs. But for the methamphetamines, we didn't directly look at whether, I mean, we did look at if their cravings were self-report on the cravings being reduced, if they stopped using the drugs like meth and fentanyl while taking the buprenorphine medication. We did look at that. So we do have some data on that, but we didn't purposely, look at methamphetamines versus those not taking methamphetamines and the effect, or those in the telehealth versus not telehealth who are using methamphetamines and the methamphetamine specifically. I guess we could look at that if the methamphetamine specifically was reduced more among those in telehealth, which it may have been because that was our finding. The ones doing telehealth did have those reductions. So thank you for that question. I guess we can look specifically at that.
So the folks so the folks with telehealth were getting regular urine drug screening as well?
Yes, everybody. So everybody came to the library, whether they're in the telehealth or control group. Saw us and we did the drug screenings, the urine drug screenings. It was self-administered. They took it. We gave them the cup and the test strips, and they took it to the bathroom and then came back with it, and we recorded it. So we didn't like go in the bathroom and watch them. Sometimes we're outside the bathroom, just so that they wouldn't be a target of security. But
yeah, it would be great. It would be great to look to see if there was fewer methamphetamine positive urine drug screens with the initiation of buprenorphine in that setting. If that was one of the anecdotal or one of the kind of more qualitative findings that you're having. So I would be very interested in that. So I encourage it.
I'm going to read the next question in the chat, Jill, and then it's you. But there's a question from Tim Wilkins saying, what will the primary endpoint be for the randomized control trial for the R1? And also, it seems there could be interventions to engage in the baseline evaluation. 200 to 60 is large attrition. So 2 questions in one.
Yeah. Okay. Starting with the last one, the baseline, the attrition was actually among the 60 that enrolled. So the 200 that were screened, they didn't end up seeing the doctor in person the first time to get further confirmation that they were eligible for buprenorphine, or they didn't see the doctor to get the buprenorphine. So I think I'm sorry.
No. I guess that's where he's going at, right? That how could we decrease that 200 to 60? Like, why did so many people not go see the doctor at that first stage, right?
Yes, I know. And at first, with this being a telehealth study, it would have been great if they could just see the doctor on telehealth for the first visit and not go in person. But the medical the doctors do want to see them in person, at least at Father Joe's the first time. So honoring that, I think, yeah, I think it. So trying to get them enrolled. Well, there was a lot of barriers at first with, even though it's the same day, no wait kind of thing that they could get it. Sometimes there was several hours waiting. So that was kind of a barrier, or we would actually walk them in sometimes to help them. But it seemed to be more of a barrier at the beginning, just like with different things going on. Yeah, so it's a lot of it could be motivation, like they're just coming in to do the $20 survey that day. They needed that, but they weren't really that serious about going to the doctor and getting the buprenorphine. So it was just a lot of things that were barriers. So I guess I think the follow-up, like the next day follow-up, would be a big thing we would try.
Would it be feasible to have the doctor at the library? Is it are there any legal implications to that?
It was, Father Joe's even proposed that at one point. However, we're trying to, so when I'm talking to the funders, we're trying to keep it, feasible and low cost. So other libraries throughout the US, they may not be able to do that, have a doctor in the library. So that was kind of thrown out, that idea. But, I don't know. Yeah.
I would defer to other people on this, but if they're prescribing medications from a non-licensed base, there could be some legal implications there. As it's a research study. I don't know. I'm looking to others who maybe have more thoughts on this. Certainly, if you'd like if there was a mobile unit that was a licensed clinical space that you could use that was they could go outside to the mobile unit to do it. And sorry that I just jumped in, but I agree. I mean, it seems like that is a little bit of a barrier, just the going to Father Joe's. And if there was a way to bring them closer, but I think you'd have to be very careful about the prescription from a non-licensed space. I don't know if anyone, I see Richard on here and others who've maybe worked in these spaces, whether you're allowed to have, if you can do prescriptions of things from spaces that aren't licensed.
Yeah, the mobile van. So Father Joe's also has that mobile van.
Right.
So that was great too. But then we would be testing the mobile van, right? So
right.
We didn't go that route either.
Right.
But yeah, they were willing to come to the library because they used to do that. So that I did want to go back to, and hi Jill, but I did want to go back to answering the first part of that question that Timothy Wilkin had around the primary endpoint for the randomized trial. So it would be the same as our as this pilot in terms of the buprenorphine, drug screens, so uptake and retention in buprenorphine, as well as going to the medical appointments more than those in the control. However, we also are moving towards looking at abstinence because the program officer said it's, I think that's NIDA would probably also appreciate that, seeing even a 7-day or a 1-week abstinence of drugs, whether fentanyl or other drugs, because a lot of this was harm reduction, preventing overdoses, helping to prevent overdoses. Sometimes they were taking the buprenorphine and still taking the fentanyl and other drugs, but they reduced it. So, but also look more at abstinence. So we would attempt to look at that too, or strive for that.
Are you going to include any I don't know the right way to say it. I guess it would be costing or economic or quality of life, just because it was pretty compelling. I think in the video, people were getting a job, and how do you capture all of that kind of positive social benefit, both to the participant and to the community at large? Because I think, trying to, framing some of the value and it saves costs overall, I think can be kind of compelling rationale.
Yes. So, yes, I think gathering the costs, economic costs, but also we did have a very large survey, baseline, and then follow-ups too, that did capture a lot of that. Quality of life issues. We had a lot of measures. So I think it's just a matter of me reporting those more, but we'll definitely use the same measures and questions. So, changes in mental health and employment and housing, especially, we had all of that.
Hey, Jill's turn now.
Sorry, I jumped in about something else, but it was connected. Lianne, this was so great. I'm blown away by all this work. I think it's compelling. It's so interesting. You brought up the issue about follow-up and with everything that we're talking about. Something that I have been struggling with in studies where we have people who are unhoused and are moving around or out, and you mentioned follow-up, and it's this the phone issue. And I think this is a very big issue for studies for people who use drugs, who inject drugs, who are, unhoused, who don't have phone access. And we have a study where we're gonna try to pay for some phones for some people. It used to be actually I think a reasonable cost. It now seems like it's so expensive to do it. And I'm just curious if y'all thought about that, because I was like, can we just buy a bunch of burner phones and do really cheap plans? But even with that, it's really hard. And of course, the comment in someone who maybe doesn't have, their belongings are so safe and secure, like would the phone just get stolen so that you'd be doing it again? But if we can't connect with people again, like, it's just going to be so much lost to follow up. So I don't know. I don't know what the question is if you thought about trying to purchase phones, and then the question to the rest of the group, have people found cheaper ways to do this? Because we're doing it through UCSD, and it's probably going to be $500 to $600 a person per year per phone if we decide to do it like through UCSD with their plans, which is more expensive. But anyway, it was just wondering what you thought about that. And
yeah, because throughout the study, just down the street downtown, they had a couple of tables outside, not far from Father Joe's, where they would give out phones every day for at least for $20, right? So participants, whenever they lost their phone, they would take our $20 sometimes and just go get another phone. So I feel like it should be $20, not what you're talking about.
Oh, it has, well, I'm assuming the $20, they still have to hook up to internet. So this is the idea of actually having a plan, right? And I'm talking about per year, and plans. Seems like the cheapest plans are now like $25 to $30 a month. Yes, you can get a phone, but you'd have to be able to, find Wi-Fi, which is, now more and more reasonable that you can get it. But if you actually wanted someone to have a plan, that ends up adding cost. But that's very interesting. That's great to know that even just going down the street and getting $20 phone is part of that. But yeah, that's the issue that I see is, the Wi-Fi issue.
Yeah, and partly the library helps with that Wi-Fi issue, but
But that may be something that you want to consider for your R01, is that if maybe working with one of the down the street groups for these cheaper phones, like being able to supply them yourself, as opposed to just being like, here's 20, you have to go down the street, come back and do it, but to show that that's sort of built in to the study of like ongoing support and ways to communicate. And maybe just do it on the cheap.
Yeah, I love that idea. I even have a neighbor who on the side does that kind of thing with the phones. So with whatever company, Verizon, whatever. So she even said, "Oh, can she come to the library and sign people up for phones?" So yeah.
We need to get you to come to the AVRC to do this.
Yeah, I can
talk to you later.
Yeah, I'll give you her contact. Yeah, I will.
Thanks. But that's good to know. And I just would consider factoring that in because that might be a way that will help you with follow-up and retention potentially if you can effectively get a hold of them.
Yeah.
Sarah, I see you've turned on your video. Do you have a question?
Yeah, thank you, Lianne. This was really interesting. And I think part of what's so innovative is you've found a location where the people are. Instead of trying to bring them or move them and I think that's also what you're talking about with the like subsidized phones. Like a lot of the resources are already there. So I'm curious as you think about the build out. One of the things I thought of was which pharmacy are we using? So what's the next step? What's the like? Is there for those that are going in person to Father Joe's? Are they using an on-site pharmacy?
Yeah.
And then what other build outs do you see to really keep those barriers minimal, especially the type of transportation barriers and or just the movement and the process of getting the medications?
Right, yeah. So with pharmacy, primarily they went to the CVS downtown or to Allen Pharmacy. We tried to, at first we just wanted them all to go to one pharmacy, and really almost everyone did just go to CVS pharmacy. But Father Joseph wanted not to do too much that's out of the norm. So that happens to be what the norm was. So we kind of just went with that. But there were a lot of challenges because they required the photo ID. And I think that's a federal requirement. So it's can't really get around it. But I don't know why they can't, once they do pick up once, even if there's other medications, if they had their a copy of the photo ID on file, why can't they just go with that instead of them having to have a photo ID every single time? But so that's I will work, I think more closely with the pharmacy to try to see if there's any way to overcome that barrier. But yeah, we didn't have a whole lot of variation with pharmacies, which was good because we didn't want that to be a factor, difference between participants. The transportation issue, we tried to, because Mission Valley was more of a challenge. It's farther away, that library, from downtown Father Joe's. So, and some really didn't want to go to downtown, the environment at all. So, we were giving the transportation passes every week as well. I forgot to mention that. And even that they still didn't always want to go downtown. So we did move towards thinking about Uber or taxi. We did get the green light to do it from the funders, but in the end we didn't end up having to do it. I think if it was Mission Valley, that would, or farther away ones, that would be helpful. But at the R1, I'm just proposing it now just at the downtown library, and then maybe a future one could be scaled up in other cities. But because we already showed that it can work at more than one library, they're saying it's okay to just propose one. Hopefully the reviewers will be also okay with that.
I see that Laura has her video on as well.
Hi, Lianne. Really great study. Thank you so much for doing this incredible work. Just like two quick questions. One, and I may have missed it. What was the dose of the Suboxone that you're using? Is it pretty standard across participants or provider dependent?
Well, provider dependent, but participant dependent, right? It was supposed to be tailored to their needs. So some have had experience with buprenorphine in the past, so they might be started at a higher dose, and then some just had no experience at all with it. So a lot of times they were started at a 2 milligram kind of dose, like gradually giving it to them, but so it really varied. It depended on the person, but in general, I think the practice was to try to give them more like 8 or 16, like 16 milligrams would be good. So I wonder if those who are at the low dose, if they were having trouble feeling the effects. So it seemed to be kind of not set in stone, something that was a huge issue too, is trying to get the right dose for the patient to feel like it was the right dose.
I think it's a rapidly evolving field, and yeah, I think when I started doing this, yeah, it was like 8, 16 a day, and now we're trying to get 24 to 32. 32 kind of the maximum where you kind of plateau, with mu receptor activation. But maybe that's part of it too, is really trying to get folks on at least 24 milligrams at first day if they're using fentanyl, even if they don't, have experience with prior buprenorphine. And then one other thing is, before I moved out here, it was like right at the beginning of the pandemic, and I was in Philadelphia, and I was seeing patients in a syringe service program there, and when everything shut down and we were doing telehealth, we ran into the same problem of my patients not having phones. And so one solution was the clinic where I was working was like 5 miles from the syringe service program. So the patients could still go to the syringe service program. They'd be given an iPad or a phone there to then do telehealth with me. And so maybe that's another option, or folks could go to Father Joe's and at least do the telehealth, when it's more convenient for them, to the library. But then also with incentives, I think, one thing that we found is that the more incentives you could give folks to come in, either meals or toiletries, things like that, it really helped people come and get a whole host of services.
Yes. I love that syringe service program model for that, and in a way that's probably what we were mimicking in the end at the library, because they definitely did appreciate all those other things. Precipitory withdrawal was really something they were concerned about, especially those who've never had, buprenorphine. So could be a lot of it just fears, and so that's why they were afraid to take a large dose, thinking they were going to go through those withdrawals. I don't know how to,
Just to understand how telehealth can, now that Laura was saying that, would it be possible for them to just get the telehealth appointment from anywhere if they have data? Like, could they have gotten their next telehealth appointment from, a shelter or wherever they were, if they just had internet?
Yes, I mean, yes, they can do that, and they can also, not have to go to the library. If they had internet access, they could do telehealth. So we're just, because it's a research study, we want to take out those other, confounding factors. So we're trying to stick to one medical provider and one, as much as possible pharmacy.
Because the idea to me is that if they get started at the library because they happen to be there, but then they just keep going on the telehealth, that's it. You've kind of like initiated somebody and they can just keep going on their own. But yes, I assume that attrition would be much higher without having those incentives to come every week. Patty Zuniga was, she sent in a direct message that accessible public phone stations or booth within shelters may help for that, or if there are other spaces where they can just kind of get their telehealth appointment.
Yeah, I mean, one moved out of town and wanted to continue to do the telehealth from wherever they're at, and so they probably did. I mean, they weren't part of the study anymore, but they are able to.
And then there was one question from Lucas Hill asking about coverage of the Suboxone for those without insurance. How was that handled?
Right. So Father Joe's it did cover it because they get private donations, so they're able to get free medications no matter what. But for the most part, people have Medi-Cal, so that would cover it. That covered it. But yeah, it was just, I think there was a lot of misperception on the street that they would need to have insurance. That kind of prompted me to do the study in the first place, because they just seemed like they didn't know where to go and they didn't think it would be covered. And then I found out, oh, Father Joe's will do it for free.
I had one last question, and we still have 4 minutes. So I was wondering if for your R01, you were planning on, you had said that you would introduce a case management based on your supplement, or whether you left the case management out.
The case management role of the research staff, it's sort of, I mean, I think it just is part of it. So yes, and also helping them, navigate doing the telehealth and the doctors. So we would keep that in there.
But the problem is that once the research staff is no longer there, then it's not like a real situation, right?
That's why. Yeah, go ahead.
The training of the staff at the library, but also social workers just kind of coming once a week or so to kind of reproduce what will happen once you're no longer there.
Yeah, so that's why I love what you brought up at the beginning about the training, because training the staff, and now social work interns, social workers in libraries is a big thing now in the country. So training them to do it, because it's not, well, they're doing case management and on some level already, not part of the study in the libraries. So this could be just part of that.
So there's a lot here on, fingers crossed you get the R1 funded so we can keep this work going. From Richard, an excellent presentation, such a great project, appreciate your creativity and hard work, and nice to see you, Lianne, and congratulations on the job. So I think we're all hoping the same. Let's hope that R1 makes it despite the turmoil.
Thank you.
And also, given that we have 2 minutes left, it's our chance to say goodbye to Jill for a few weeks. And good luck. And I hope you get some sleep.
More than a few weeks, many weeks.
Yes. I'm just thinking a few weeks, it makes me feel better.
What's happening? Are you getting another baby?
Yeah, there's a baby coming on Monday. We
Oh my
hope. No, I didn't mean it like that. Like we hope it will last until Monday, so we can keep planning. Yes, another baby. So y'all are in the wonderful hands of Anik and Dan, and thank you.
We'll try to survive.
You'll survive.
Yes. Great. Well, thanks so much, Lianne. This was so interesting, and I really hope it works out. It's a great project, and thanks everybody for coming, and happy weekend, everyone. And see you next week.
Thank you.
Bye.
Bye.